guys, all the students, rheumatoid hand is a common short case and sometimes long case. Having said that, Professor Kumar has just explained to you that the rheumatologist has actually decreased the burden of rheumatoid surgery significantly in last few decades. So we don't see the rheumatoid arthritis as we used to. Just like polio, it's a kind of a dying surgical thing, but exactly like polio, the concepts, if you understand the concepts of management of rheumatoid hand, or you can extrapolate that to any other hand problem. So the main idea is not to tell you detail about how to deal with rheumatoid uh, hand itself. The idea is to tell you the basic concepts of understanding the rheumatoid hand and understanding the management of it. So you will have you will gain few things from it. A, you will understand rheumatoid itself and the other hand problem, how to deal with it. B, it will give you a kind of a problem solving mind in the exam, that sometime if you're faced with a complex problem, then how to deal with it, even if you don't know the detail. If you know the basic concepts, you can answer questions in a very scientific way, so that the examiner is satisfied that you're thinking in the right track. So even you don't know the absolute precise detail, it really doesn't matter. So with that aim in mind, we will proceed. So the aim of this particular case, or whenever you see a rheumatoid hand, either in the clinic or in the exam, what we expect from you, or what the patient expect from you, is first you confirm that this is a rheumatoid arthritis, and then you assess the deformation of different joints and assess the function. And this can be easily done quite often by simple history, physical examination, and some basic investigation. You don't need too much detail in rheumatoid arthritis. And obviously, the second aim is, once you've confirmed the diagnosis and assessed the deformities and function, the second aim is to how do you manage it. And for that, you have to always think patient as a whole, rather than just focusing on one finger or one hand. And then think of what are you giving to your patients, because rheumatoid arthritis can present with significant deformities and may not have any much functional loss, or even if he has functional loss, your surgery may not provide him too much help. So you have to always think, how is my intervention going to benefit this patient? So this is all you require. You require a diagnosis, assessment of function and deformities, and then you have to think hard, is my intervention going to help this patient? And that, if you understand from this talk, I think I have fulfilled my duty. So that's what we'll go to today. So whenever you see a case of rheumatoid arthritis, sometime, as Professor Gopakumar said, it can be quite complex way to think about, where should I start? What do I tell patient? Or what do I tell, if you're in an exam session, what do I tell the examiner? So you come at hand here. Diagnosis is not difficult, but you don't know where to start. So first thing we want everybody to is this a rheumatoid arthritis or not? Or in other words, when do you call any arthritis a rheumatoid arthritis? And a lot of students get this confused because they immediately focus on the Z deformity of thumb or finger going swan neck or boutonniere, and they start talking about this. Actually, none of these deformities are described. They develop later on, but none of them are actually as a diagnostic criteria for rheumatoid arthritis. So first sentence when you're presenting a case of rheumatoid arthritis, either as a short case or a long case, once you have taken your history, is this, which we want all of you to say, that this is a polyarticular symmetrical arthropathy involving multiple joint of hand and wrist. And just mind this, my long sentence. When I saying this sentence has got some meaning in it. So when you come to diagnose rheumatoid arthritis, we we know that there are diagnostic criteria for rheumatoid arthritis. So the old style, there is a bit of change. I'll come to that in a minute. But this is still, for orthopedic surgeon, this is still the case because we see cases a bit later. Rheumatologists want to see them early and early because they want to start medicine early. But we'll come to that in a minute. But for us, this is good enough criteria. So what are the 7 criteria? Even if you don't know, again in the exam you can forget. These criteria, it doesn't matter if you forget, as long as you know the criteria is based on some history, some physical examination, some investigation. So even if you remember one each of these these things, you will be fine. So history is more than 6 weeks history of morning stiffness that the patient will give you. On examination, if you see few joints involving peripheral arthritis, especially involving hand and wrist or in feet, that is a good indicator that it could be a rheumatoid arthritis. Especially if it is hand, then that gives you an extra point. If it is symmetrical, that gives you a bit extra point. And then once you got this examination of these 3 points, then you are doing some investigation. So if your classical X-ray shows your osteopenia with erosion, and then one blood test rheumatoid factor, you are almost made a diagnosis. Sometime a rheumatoid nodule, if you see on the extensor aspect, something like this. So if you go back and you see this rheumatoid nodule, and what I told you that this is a symmetrical arthritis involving many joints of hand and wrist. So I already in my sentence, I've told you it is involving hand, it is involving many joints, it is symmetrical, and I've shown you a nodule, and I've already made a diagnosis. You don't need anything else. Okay, so that's why we want you to approach any arthritis with this in mind, that is it fulfilling the criteria of rheumatoid arthritis. And that's how, when you want to present your case, this should be a first sentence. In fact, in FRCS, when we in England, we want them to give diagnosis almost immediately. When we say, okay, what do you think about, either in viva when you show photographs, or in a clinical case when you see the patient, we say, just inspect this patient, tell us what you see. And if the first sentence they say symmetrical polyarthropathy involving multiple joint of hand and wrist, and I can also see some rheumatoid nodule in the back of the hand or forearm or elbow, most likely this is going to be a rheumatoid arthritis. So that's a good start. That's how we want you to start. Now let's see the problem with these diagnostic criteria and why we have changed it. There are a few problems with this. One is this problem with this rheumatoid factor, which is actually an IgM against the IgG, because it's autoimmune disease. It is present in normal population up to 15%, and it may be not, it is not always present in all rheumatoid arthritis, and it can be present in other conditions. So it may not be very specific. It is reasonably sensitive, but not very specific. So there can be a problem with including rheumatoid factor as a criteria. So what should we change the criteria? So this is what we came in 2010. And again, I don't want you to go to absolutely no detail into it, but remember, this criteria is also based exactly same history. So same history, 6 weeks or less than 6 weeks, physical examination, mean examining all the joints, which are all the joints involved, and they're given a scoring system. So a large joint, small joint, many joints. So don't go into detail of that. History, physical examination, finding out which joint is actually involved, and then you can have a scoring system. Most important, if you can get anything from this slide, is that other than rheumatoid factors, we have added few blood tests, and which we should be, all of us should aware of, and which we should routinely do it. One is this anti-CCP, or anti-cyclic citrullinated protein, it is called, or some people call it ACPA. So anti-CCP actually is more specific than rheumatoid arthritis. So this is a very good test, and not as good, but better than your rheumatoid factor, because it probably is as sensitive but more specific. So remember, anti-CCP is to be added to those criteria, 7 criteria I told you. The other thing is that inflammatory markers were not included there. So we have included the usual inflammatory markers, CRP and ESR. So other than those, these 3 extra blood tests you should know: ACCP, CRP, and your ESR. And few things they have taken out. And for orthopedic surgeon, you should not worry too much about, because we still rely on these. And I'll tell you why. The reason is that the reason they have taken out is because of the disease modifying drugs. Nowadays, they want to start as early as possible, because they want to the remission or the inflammatory load to decrease as early as possible. So for them, the diagnosis is very early. So the one we said that it is symmetrical, symmetry may start asymmetrical and then become symmetry. So they don't want to early on to say that symmetry is important. The other thing is that the X-ray finding also can be a late finding. So they want to pick up at synovitis stage so that they can treat it. So for them, it is important that that X-ray is not included in this criteria. So the symmetry is taken away, the X-ray is taken away, and the rheumatoid nodule, again, that is A, it is not that common, maybe about 20% or so. And B, again, it can be a late finding. So some things have been taken off for orthopedic surgeon. If you find symmetrical involvement, if you find a nodule and you find classical changes, which most likely you'll find, and that's a good criteria for. So you need to remember both. Remember, this is a criteria for rheumatologists because they want to pick up early. But on those criteria, just add your 3 blood tests and you should be fine. Okay. So once you made a diagnosis, when you come to a rheumatoid hand, the problem, as I was mentioning, is that is to follow a systemic pattern of examining these patients, and that's what I want you to learn today, to how to present a case of rheumatoid arthritis, because it's not just one joint it is involving multiple joints. So you need to have a system in your mind so that the examiner understand that you're not jumping from one joint to other joint. So this is my protocol. I start with wrist and distal radioulnar joint. I then go distally to MCP, then talk about finger and talk about thumb. So I talk about these four joints or 4 reasons when I'm presenting a case. Even before you start from the wrist or distal radioulnar joint, if the examiners tell you, okay, examine this patient, I would like you to remember that you want to examine the patient as a whole. So tell the examiner, ideally, I would like to examine this patient as a whole, especially the proximal joints of the shoulder and elbow in the upper limb, and then proceed with lower limb examination. And examiner will say, thank you very much. You understand the concept. Go ahead and examine this patient's wrist. Okay, so that's where we will start today. So let us first come to not only the wrist, let us first come to a distal radioulnar joint. So what's happening in the distal radioulnar joint in rheumatoid arthritis? So when you are actually examining a rheumatoid arthritis, there is a lot of so-called, we call it cliche, or a lot of things which you will repeat many times, but there's no harm repeating it. And having that concept in your mind that and going through that system. So whichever joint, it really doesn't matter whether it's wrist, distal radioulnar joint, finger or thumb. Think of what is happening in this joint, i.e. rheumatoid arthritis, synovitis leading to destruction of ligaments and tendons, if tendons has got synovium on that. And that is leading to some structure not functioning and some over functioning. Something is lacking and something is pulling or pushing, and that is causing deformity. So there's plenty of time of thinking in your mind that that sequence of anything what is happening. So that's what we will do for everything. So let's start with distal radioulnar joint. I'm not talking about radiocarpal joint here, just distal radioulnar joint. So I'm breaking it into 2, DRUJ and wrist. So there is synovitis in distal radioulnar joint. Synovitis lead to the destruction of all the ligaments and structures which is holding this joint together. On the top of the distal radioulnar joint, there is a tendon which is quite close to it, and it leads to tenosynovitis of that tendon. That tendon is extensor carpi ulnaris. That tendon, once it becomes synovitis, it loses supports and it subluxed to volar wall. On the volar side, there is no support left for this ulna, And because this extensor carpi ulnaris also form an important subsheath of the TFCC, which is a very important stabilizing structure for distal radioulnar joint. So there is no stability of distal radioulnar joint, and there is nothing in the back of it. The ulna actually almost dislocate or move on the dorsal side. And when it moves on the dorsal side, there are a number of extensor tendon which already got tenosynovitis and ischemic, and they are tenting on this distal ulna, and which causes them either mechanically rubbing against it, or because of tenting of it, they are already tenosynovized, they become ischemic, and it causes multiple tendon rupture. And this lump of bone, which is on the back of your wrist with synovitis all around it, it's called caput ulna. So in short, sir, I can see caput ulna with few tendon rupture if they're there. So that's all you need to know in the distal radioulnar joint. Nothing great about it. You understand that how this sequence has happened, which I just told you, and just tell the examiner, this is what's happening and this is what I'm seeing here.